Bismillah ar-Rahman ar-Rahim. Fifth year medical student at College of Medicine, University of Diyala. Now we come to the second lecture of GIT disorders, which is chronic diarrhea and malabsorption. Here you see a case scenario of a 5-year-old child who is referred with chronic diarrhea over the last year. He has been stooling 5 times per day, passing a loose watery stool every time. It is associated with crumpy abdominal pain, usually after each feed. Examination revealed pale boy with mild abdominal distension, and his body weight is below 5th centile. So from this case scenario, you have a child, whether male or female, with chronic diarrhea. That means it is more than 2 to 3 weeks, and you should discuss with the mother whether this child has really diarrhea. As you know from previous lecture, that diarrhea means an increase in the bulk of stool pass per day, change in the consistency, fluidity, and volume of the stool. The next point, you should take further point in the history describing the stool passed by this boy, whether the stool is bulky, greasy, offensive, pale. This means that this stool is of malabsorptive stool. So you have to be sure about the type of stool passed. The other point, you should check in the history whether any change in the body weight. So the mother will tell you that his body weight was change and decreasing over this long duration of illness. The other point, the relationship of this diarrhea with food intake. So when he or she stop feeding, diarrhea whether stop or continue, because you know from previous lecture that there is 2 types of diarrhea, whether osmotic and secretory. So when it is osmotic, it may stop, especially when taking milk. So first thing, you assess whether the child is thriving well. Second, whether it is a true diarrhea. Third thing, in the history, you can guess whether this diarrhea is functional or secondary to malabsorption or an inflammatory diarrhea. As well as, does it stop if nil by mouth, I mean osmotic, not secretory in origin. The most important part of assessment of a child with chronic diarrhea is careful history and the clinical examination. So you have to assess the weight gain and the linear growth. So you have to check the body weight and the height or length of the child. The body weight and height, you should put them on the growth chart and be sure that it is below than expected for that particular age. The other thing in the examination, you should assess the signs of malnutrition, like loss of subcutaneous fat and muscle bulk, whether it is decreased or normal. So you have to assess the area in the axillary, medial aspect of the thigh, and the interscapular region, as well as the buttock region. You should check them for loss of subcutaneous fat and wasting of the muscle. The other important area that should be visualized is the perianal area to check for any excoriation from acidic stool. And also you may check for rectal prolapse, soiling, or any other perianal signs of inflammatory bowel disease. As well as you may do, after completing examination, you do rectal examination. So you check the characteristic of the stool is very essential in the history, whether this stool is a malabsorptive stool or some sort of functional diarrhea. When you complete the history taking and you did the physical examination, also don't forget to check for any signs of anemia or pallor. You should check for mucous membrane, the conjunctiva, and you look for the pallor in the hand. So next thing you do to reach the diagnosis or differential diagnosis is the investigation, which should be done for a child with a chronic diarrhea. And this investigation usually dependent on the clinical situation and outcome of your clinical assessment. So there are many tests done for such a patient, but there are what we call basic screening of patient with a chronic diarrhea. So you check stool for any infectious agent like Giardia or other chronic bacterial infection like E. coli, and you do full blood count for anemia and type of anemia, whether iron deficiency anemia, microcytic hypochromic, or macrocytic anemia in cases of folate deficiency. You may send the child for screening of gluten-sensitive enteropath. We will talk it later on. You send for antibodies like anti-tissue triacylglutaminase antibodies, IgA type, and you check for serum albumin, whether there is decrease in the level of serum protein. Stool testing, sometimes you check for the pH of the stool, which is usually acidic in cases of malabsorption. You check for reducing substance, malabsorption of sugar, and microbiological investigation for microscope and culture of the stool, virology, ova, and cyst parasite in the stool. So you check for stool osmotic gap, the difference between measured and calculated osmolality, which can be measured in a liquid stool. So stool osmolality should usually be the same as plasma osmolality, normally. So stool osmotic gap equal to stool osmolality minus 2 multiplied by stool sodium plus potassium. This equation, you will find it in other books and references mentioned at the end of the lecture. So significant gap, more than 40, suggests osmotic diarrhea, with the gap reflecting the ingested non-absorbed agent. Consider possible laxative abuse or others. If no gap, implies impaired electrolyte transport, which is seen in secretory diarrhea, like cholera and E. coli. Low stool osmolality suggests contamination of the stool with water or urine, or an excess of ingested hypotonic fluid. Also, you examine for the pus cell in the stool and occult blood. Occult blood in cases of inflammatory bowel disease. The other point in case of inflammatory bowel disease, you may check for fecal calprotectin as a stable neutrophil protein present in the stool. So you may check for this particular protein, which is non-specific marker of bowel inflammation. High level mean inflammatory bowel disease, which should be considered. The other point in cases of chronic diarrhea is fecal elastase, which is useful test for pancreatic insufficiency, manifested by low level of this enzyme. Low value may also be found in short gut and bacterial overgrowth. Normal level of this enzyme elastase exclude pancreatic insufficiency. The other point in the stool, you may check A1 antitrypsin, which is serum protein not present in the diet with the same molecular weight as albumin. So fecal level of this protein reflect enteric protein loss. I mean in cases of protein-losing enteropath. Blood testing, as I told you, complete blood count to check for anemia and type of anemia. You may do blood film and basic biochemistry, including the inflammatory markers and albumin level, immunoglobulin, and celiac secrete. Fat-soluble vitamin should also be checked in cases of fat malabsorption. You know, fat-soluble vitamins, A, D, E, K. These can range from simple to relatively benign disorders such as IgA deficiency to major life-threatening immune deficiency, immunoglobulin, such as severe combined immune deficiency, which lead to severe infection of the GIT and slow or no recovery from that episode of infection. Full immunology workup is required if an immune deficit is suspected. The other test that may be used if you are suspecting laxative abuse, I mean the mother can give the laxative to the child and some sort of child abuse, so you have to check urine laxative secrete. Administration of an osmotic laxative will result in an increased osmotic gap on stool analysis. The other thing, which is rare in our locality, is the screening for cystic fibrosis. So you check for sweat test when there is associated recurrent chest infection and the clubbing of the finger, and probably with or without family history. So we check for sweat test, sweat chloride test, and cystic fibrosis genotype are indicated. Hydrogen breath test can be used to test for carbohydrate malabsorption. Although there are significant false positive and false negative results, and children below 4 years find it difficult to cooperate. The potential of offending carbohydrate is given and the breath hydrogen monitored with the peak from fermentation suggesting malabsorption. The other maybe invasive test used, especially if you are suspecting case of malabsorption or the other tests are negative and yielding no satisfactory result, you may do endoscopy. So gastroenteroscopy with multiple duodenal biopsies is indicated if an enteropathy like celiac disease, cow's milk protein intolerance, or enteropath post-enteritis syndrome is suspected. So you do gastroscopy and colonoscopy plus small bowel imaging are indicated in inflammatory bowel disease or colitis is suspected. So this will give you a histopathologic diagnosis of the underlying pathology. You may have red flag signs when you deal with a child with chronic diarrhea. So these should be kept in mind. You should always ask yourself about these points, especially in the history and the examination, which include continuous diarrhea, especially at night, acidic stool, blood and mucus in the stool, failure to thrive, and any associated symptom that suggests organic disease, like fever, rash, and arthritis. So these points should be kept in mind. So now we come to the next slide, please. Here you see chronic diarrhea is defined as a diarrhea episode lasts more than 14 days. In Iraq, is often the result of an infectious process that lasts longer than expected, and this syndrome is defined as a protracted diarrhea or intractable diarrhea. There is no clear distinction between protracted and chronic diarrhea. In well-developed countries, it is less common, and the etiology is more diverse, showing an age-related pattern. This scheme shows you the chronic diarrhea differential diagnosis. Here, steatorrhea and large bowel problem. So more than 3 loose stool per day, more than 14 days, exclude chronic inflammation. Chronic diarrhea, here you take steatorrhea, oily, foul, difficult to flush. Maldigestion, pancreatic insufficiency, malabsorption, whether primary or secondary. Here, mucosal disease, celiac disease, ileal Crohn's disease, secondary to short bowel resection of the bowel, bacterial growth, mesenteric ischemia, and liver cholestasis, because bile salt is very essential for digestion and absorption. Here you have large bowel problem, small volume of stool, bloody and painful with tenesmus and urgency. You may see abnormalities with motility, irritable bowel syndrome, or hyperthyroidism, an inflammatory bowel disease, radiation colitis, ischemic colitis, or secondary to cancer, villous adenoma, and microscopic colitis. The other part of the scheme here is small bowel disease. Here, more than 3 stool per day, more than 14 days, and exclude chronic inflammation, chronic diarrhea. Here, problem in the small bowel. The volume of the stool is large, bulky, offensive, watery, no pain, and there is weight loss and no blood, and the child looks malnourished and failure to thrive. So you have 3 differential in this category. You have secretory diarrhea, mucosal, Crohn's disease, celiac disease, chronic inflammation, and Weber's disease. Tumors like neuroendocrine, carcinoma, vasoactive intestinal vasoactive intestinal peptidoma, carcinoid syndrome, and mastocytosis. Here histamine is released. Neoplasia, adenocarcinoma, and lymphoma. Disordered motility, irritable bowel syndrome, diabetic neuropathy, autonomic neuropath, and hyperthyroidism. Osmotic in cases of magnesium sulfate ingestion intake, carbohydrate malabsorption, glucose galactose, and lactose intolerance present in milk disaccharide malabsorption, whether primary or secondary deficiency. Pathophysiology, as mentioned earlier before, you saw in previous lecture, secretory diarrhea and osmotic diarrhea, and this usually shows large volume of watery stool and persists when oral intake is stopped. In osmotic diarrhea, depending on oral feed, so stool volume is usually not as massive as secretory diarrhea and stop when you stop oral intake. Here you see a pathway of osmotic diarrhea and secretory diarrhea. You see there is secretion of water and electrolyte, especially when there is food intake here, it increases molarity inside this area, inside bowel loop, so the fluid will come from interstitial toward the bowel lumen. So the volume will still respond to fasting and stool osmolality and ion gap, as I told you before, moderately increased volume, diarrhea stall when you stop intake, and normal to increase anion gap 100 and more milliosmol per kg. In secreted diarrhea, the very large volume, diarrhea continue when you stop food intake, and the osmolality is normal, and the anion gap between the stool and the plasma is less than 100 milliosmol per kg. Here, infectious and infectious causes of chronic diarrhea, as I told you before, bacterial, viral, protozoal, small sample growth, post-enteritis, tropical superflu, and disease. Here, excessive intake of carbonated beverage fluid, dietetic food containing sorbitol, mannitol, or xylitol, excessive intake of antacid, laxative containing lactulose, and magnesium salt, magnesium hydroxide. Excessive intake of a drink containing methyl xanthine, cholate, and coffee. Here, abnormal digestive process in cases of cystic fibrosis and Schwachman-Diamond syndrome, which is abnormality in the pancreas, or isolated mechanism deficiency, chronic pancreatitis, Johansen-Blizzard syndrome. All of these are rare syndrome. Also, trypsinogene, enterokinase, chronic cholestasis, use of bile acid sequestrant in cases of chronic liver disease, and bile salt retention, which causes the itching. So this use bile salt sequestrant, primary bile acid malabsorption, and terminal ileum resection. Like here, nutrient malabsorption, congenital acquired lactase, fructose, congenital, and so on. The list is very long. But here is celiac disease very essential in case of immune and inflammatory process. We'll talk in detail about this disease. Structure defect like microvillus inclusion disease, tufting enteropath, inherited problems, phenotypic diarrhea, hyperancephalia, case of mucopolysaccharidosis deficiency, alpha 2 beta 1 and alpha 2 beta 4 integrin deficiency, lymphangiectasia, and loss of fat and protein here, congenital chloride diarrhea, and so on. Motility disorder, as I talked before, and main cause of chronic diarrhea according to the age, first month, first 2 years, and more than 2 years up to 18 years. So you can see this table and you check for the major causes of this. Here the most important is food allergy, functional diarrhea, and celiac disease. Case of a neonate, you should think of microvillus inclusion disease, congenital short bowel syndrome, and food allergy milk, as well as you may check for Hirschsprung disease with mar rotation. So you may do ultrasound examination to exclude these abnormalities. And here you may do a test for stool eosinophil and other substance. You may check or change formula. You may lead to improvement of the problem. So here in children 2 years and less, you keep in mind functional diarrhea, food allergy, and celiac disease or cystic fibrosis if there is any here with recurrent chest infection. In more than 2 years, there may be apple juice or pear nectar, antibiotic-associated Clostridium difficile, intestinal infection, lactose intolerance, irritable bowel syndrome, and also here celiac disease may be presented in this age group. So clinical approach, as I told you before, you take proper physical examination, history taking, you assess the growth and development of the child, see the growth parameters, nutritional assessment, fat loss, muscle bulk, check weight, height, weight for height of this child. Weight is generally impaired before height, but with time, leading growth also will become affected. So assessment of nutritional status include dietary history and biochemical nutritional investigation, and you calculate the calorie intake per day. So stepwise, I told you before, start with simple investigation, non-invasive, and come to invasive investigation. Goes to the endoscopy. Here, a similar approach to a child with chronic diarrhea, and check the height of the child, whether short or not, body weight, weight loss, and you check each one step by one. So diarrhea related here to carbohydrate intake, you may have carbohydrate malabsorption, whether sucrose or lactose intolerance, primary or secondary. Here also primary or secondary. Chronic diarrhea, you check weight and height, whether normal, deficiency is normal, so this may be non-specific diarrhea, functional diarrhea, or simply irritable bowel syndrome. So you may exclude excessive intake of carbonated beverage or fruit juices, decrease diarrhea will decrease. Excessive intake of carbonated fluid, decrease diarrhea will be stopped. Fat intake low, increase fat to 35 to 40% of the diet may improve this type of diarrhea. Here you may have weight loss and the stool show fat, increase stool, malabsorption, diagnostic test to determine the etiology and the specific treatment. So all these be kept in mind. Malabsorption disorder affected digestion or absorption nutrient manifest as abnormal stool. We said is bulky, offensive, greasy, pale stool. Failure to thrive or poor growth in most, but not all cases. Specific depend on the time of presentation and severity of the illness. Specific nutrient deficiency like iron, zinc, and others. Folate deficiency, either singly or in combination. True malabsorption stool, difficult to flush down the toilet and has an odor which pervades the whole house. Now we come to the celiac disease as a prototype of malabsorption. So you check this disease now and then. You may see it in Europe. They say it is 1% of the population may be affected by the disease, whether it is silent or asymptomatic or front classical disease. So it is an enteropathy in which the Gleiden fraction of the gluten aggravate a damaging immunologic response in the proximal small intestine, duodenum and jejunum. As a consequence, the rate of migration of absorptive cell moving up the villi enterocyte from the crypts is enormously decreased, but is inadequate to compensate for increased cell loss from the villus tips. Villi turned out to be progressively shorter and then absent, leaving the flat mucosa. They call it total or subtotal villus atrophy on biopsy. Classically, children present the first few years of life with failure to thrive following the reduction of gluten in the diet, cereal. So the child will have general irritability, abdominal stool, abdominal distension, and buttock wasting are the usual symptoms. And increasingly, child may present later with anemia, iron deficiency, or folate deficiency, or simply short stature. So you have to keep in mind that this child may have celiac disease. Introduction of screening test, the most important one is tissue transglutaminase antibody, and anti-endomysial antibody has provided evidence that celiac is more common than previously thought. As many as 1% in school-age children, as I told you, may be antibody positive in Western. Type 1 diabetes is about 5% in children with celiac disease. So these children are more liable to develop celiac disease. So children with diabetes should be screened yearly or annually for the presence of celiac disease, as well as autoimmune thyroiditis and children with Turner syndrome, Down syndrome. These are more liable to develop celiac disease. Here is a picture with a child with celiac. This is 1.5-year-old boy with active celiac. Note the loose skin fold in the axilla and in the medial aspect of the thigh, and the prominent ribs. Pale, hair is thin, wasted, and some mild edema here, marked proximal muscle wasting, abdominal distension. The child looks ill. Here's another child with celiac disease. There is abdominal distension, wasting, prominent ribs, thin hairs, loss of subcutaneous fat because of malabsorption. Here is a growth chart of a child with celiac disease, and this date always below the median. So at age of 14 or 15 months, start to have linear, stationary growth. Stationary, start to decrease. So when checked for celiac disease, take jejunal biopsy or duodenal biopsy, it shows some sort of villus total or subtotal villus atrophy with deepening of the crypts and the inflammatory cell infiltrate. So they stop a gluten diet here, keep the child on a gluten-free diet in this time, this point. So over time, the child will get improvement and the psychological improvement and the gaining weight. So start to gain weight on a strict gluten-free diet, as you see here. There are many manifestations of celiac disease. GIT is diarrhea, abdominal distension, vomiting, anorexia, weight loss, failure to thrive, aphthous, ulceration. Atrophy of the small bowel mucosa lead to malabsorption. Anemia, iron, and folate. Skeletal cause of calcium and vitamin D malabsorption lead to rickets and osteoporosis. Enamel hypoplasia, muscle atrophy, malnutrition. Peripheral neuropathy, vitamin B12 and B1 deficiency. Epilepsy and irritability. Short stature, puberty, delayed puberty, secondary hyperparathyroidism, malnutrition, and calcium vitamin D malabsorption. Dermatological, dermatitis herpetiformis, and alopecia areata, and erythema nodosa. These are the dermatological manifestation of celiac disease linked to autoimmunity. Respiratory, you may have idiopathic pulmonary hemosiderosis, deposition of iron in the alveoli. Other causes of flat mucosa, so you see on jejunal biopsy there is subtotal or total villus atrophy. It is not unique to the celiac disease. It may be seen in other problems like autoimmune enteropathy, tropical sepro, giardiasis, HIV enteropathy, bacterial growth, inflammatory bowel disease, Crohn's disease, esophageal gastroenteritis, cow's milk protein intolerance, soy protein enteropathy, primary immunodeficiency, whether agammaglobulinemia, severe combined immunodeficiency, وهكذا. Graft-versus-host disease, chemotherapy and radiation, protein enteropathy, protein energy malnutrition, case of kwashiorkor, tuberculosis of the intestine, lymphoma, and non-gluten food intolerance. So all cause subtotal or total villus atrophy. You see here normal mucosa of the small bowel. You see the villi, finger-like projection, and these are the crypts. And this is a normal jejunal biopsy. You see here there is a flattening of the villi, subtotal or total villus atrophy with inflammatory cell infiltration, lymphocytic infiltration, and deepening of the crypts. So this is typically found in cases of celiac disease with signs and symptoms. Clinical spectrum of celiac disease, it may be symptomatic, classical presentation, as I told you, or silent. The patient have celiac disease, but nothing appear, no apparent symptom, in spite of histologic evidence of villus atrophy when you do biopsy. In most cases, identified by serological screening in at-risk group, especially those with family history of celiac disease. Latent subjects who have normal histology here on biopsy, but at some other time before or after have shown a gluten-dependent enteropathy. potential subject with positive celiac disease serology, but without evidence of altered jejunal histology. So latent and potential may have normal histology, but here they have positive celiac screen, but without evidence of altered histology. Here they have normal histology, but over time, before or after, have shown gluten-dependent enteropath. They will have in the future. So potential, it might or might not be symptomatic. Might be symptomatic or not. So subject, they have positive serology with normal or no evidence of altered histology. So I call it potential. Ultimate diagnosis depend on demonstration of specific, though not pathognomonic histopathologic anomalies in the small intestine, as I told you. According to European Society of Pediatric Gastroenterology, Pathology and Nutrition, current criteria, the two requests of obligatory for diagnosis of celiac disease is finding of villus atrophy with hyperplasia of the crypts and abnormal surface epithelium, while the patient is on gluten, and a full clinical remission after withdrawal of gluten from the diet. So these should be present to establish the diagnosis of celiac disease. How would you manage a child with celiac disease? All products containing wheat, rye, and barley are removed strictly from the diet, and this results in resolution of symptoms. So supervision by a dietitian is essential. In children in whom the initial biopsy or the response to gluten withdrawal is doubtful, or when the disease presents before the age of 2 years, gluten challenge is required. Why? Because it may be transient problem. So you have to be sure. Demonstrate continuing susceptibility of jejunal mucosa to damage by gluten, and the gluten-free diet should be adhered to for life. The incidence of malignancy in child and adulthood is an increase in celiac, although gluten-free diet probably decreases the risk to normal. So the diet should be strict to prevent the symptoms and keep the child live normally. So always you should avoid the food containing gluten, like these 3 substances should be out of the diet of the child. Here the learning objective of your lecture. If you have any comment about the chronic diarrhea and malabsorption, you may leave a comment on the Google Classroom or YouTube, and I will very happy to answer them. You check them. These are the references from which my lecture was taken. And thank you for your listening. And if you have any comment, any question, any addendum, you can write it down in the Google Classroom or on YouTube channel. Thank you very much. See you.